Good afternoon. Welcome to Wonderful Wednesdays. And today we're going to talk about severe or acute aortic regurgitation. And by the way, this is not a cardiovascular talk only, because acute aortic regurgitation can occur after MI, it can occur after cardiac surgery, it can occur when you've dissected your aorta, or it can occur after a blunt injury. So today we're going to talk about severe aortic regurgitation. I'm going to talk about why this is so important for us and why it's so important for us to recognize it, because it is acutely life-threatening, progressing very quickly into cardiogenic shock and death if we aren't recognizing what's occurring for our patients. So I'm so glad you've joined today. I'm going to start with a case study that actually is from the American Journal of Cardiology. And this is a 16-year-old girl who's admitted to the cardiology pediatric outpatient clinic because she is presenting with symptoms of class 3, almost class 4 heart failure. 16 years old, class 3 to class 4 heart failure, which means her lungs are really wet, and she's profoundly hypotensive. She's got volume, but it's in the pulmonary veins and now causing pulmonary congestion. And she's hypotensive, extremely and profoundly short of breath, some chest discomfort, and also she has some RV dysfunction secondary to her situation. And she has dilated neck veins, non-compressible, and bilateral systemic edema. 6 months earlier, a patient was admitted to the hospital after she fell from the second floor of a building. So we're going to leave that right there. And I'm just going to say, what do you suspect? So she's had a traumatic injury, and she is now presenting with heart failure. So what do you suspect? So think about what you suspect. You don't have to answer. Obviously, we're on a talk about aortic regurgitation, so that's going to be really important. So the next thing we're going to think about, she's presenting with signs and symptoms of heart failure. You're going to put a stethoscope on her chest. And you now hear a diastolic blowing murmur, okay, 2 out of 6, a diastolic blowing or whooshing murmur heard best at the aortic site. So that gives you a clue that you're concerned that she may have traumatic aortic regurgitation. 6 months ago, she fell. So you might not have even discussed that with her when she presented in the emergency room, or she gets admitted onto your ward or into your ICU. You might not have actually been thinking about it. But one of the most important things here is her actual symptoms plus auscultating a diastolic blowing murmur. So it's shh, shh, not really even traditional lubbed up, like lubbed up, shh, lubbed up, shh. 1, 2, murmur, 1, 2, murmur occurring on diastole. You might not even hear 1 and 2. You might only hear the murmur, and that blowing, whooshing murmur is about blood going in the wrong direction. So heart sounds are really important here. In the ICU, we can barely auscultate heart sounds, but you know what? Part of that's because you use those disposable yellow stethoscopes, which are basically like putting an ear cone of paper on a patient's chest. You have to have a good stethoscope. And if you're interested in auscultation, you need to get a cardiology level stethoscope, which means it's an investment in the care that you give to your patient. Okay. So now what we're going to suspect, because we've heard that diastolic blowing, whooshing murmur, we suspect that she has aortic regurgitation. We think it's related to her traumatic injury. Okay, so let's kind of think about our aortic valve, and just remember that the aortic valve is separating the LV outflow tract. And when you look at an echo or you're reading a report, sometimes even when you're looking at a cath lab report, what you often will see when you're doing that is that there'll be some discussion about LVOT, left ventricular outflow. That means as blood flows out of the left ventricle into the ascending aorta. So that's before the carotid arteries, and it's a really important place because blood that's exiting from the left ventricle into the outflow tract and into the ascending aorta, the pressure difference that occurs when LV ejects and aorta accepts, the pressure in the aorta goes up, the pressure in the LV is lower, and the blood will flow back towards the LV, and it will fill the cusps of the aorta, and that's of the aortic valve, and that's what closes the valve. But you're going to have higher pressure in the aorta and lower pressure in the LV. Now, that aortic valve functions to prevent blood going back into the LV, and the cusps of the aorta are where the coronary arteries arise. So this is really important, because when I'm regurgitating, my blood flows from aorta back down into the LV when it should be all in the aorta. And that means that we've significantly reduced the amount of blood that's filling the bowls of the aortic valve, and therefore decreasing coronary blood flow. So really important for us to remember how vitally important the aortic valve is. And the aortic valve is essential in maintaining the appropriate direction of blood from left ventricle into the aorta during ventricular systole. Now, there's three primary components. What we're really worried about, what we're thinking about are really the cusps and the annulus. The normal aortic valve area is traditionally around 3.0 to 4.0 centimeters to the second power. Okay, and we identify that when we look at an echo. You're not worried about that. You're worried about what you're hearing. So you just want to remember that any one of these three, the annulus, the cusp, or the commissure, can actually be altered through chronic diseases, congenital diseases, chronic diseases, or congenital diseases, chronic disease like hypertension, congenital disease like Marfan syndrome, and from trauma. So it's really important to remember you have different methodologies of causing aortic valve regurgitation. Might be at the annulus, could be at the cusp, could be at the commissure. We're not actually really worried about that. As bedside nurses, we're not trying to identify where the problem is. We're trying to identify that you have aortic regurgitation. We're going to leave that up to cardiology in the cath lab or to the cardiovascular surgeon when they're evaluating the patient. And they've thought about different types of things and different types of events that cause different failures, either at the annulus and or the cusp and or the commissure. So really important to remember there's more than just one structure. It's not just the valve itself, it's the cusps, it's the commissure, and it's the annulus. So we have multiple things that can go into failure. Now, it's really important to remember when we talk about valve function. So this looks very busy. This is called a Wigger's diagram. It's a really important thing. So just take a breath. Don't get too worried about it. What I just want you to remember is that I'm going to look up here at the purple line, okay? So my LV is filling from left atria to left ventricle, and then the atria contracts, and that's the end of ventricular filling right here, and then the mitral valve closes. Now the ventricle is contracting against itself until it reaches a peak pressure. So the LV is contracting against the volume that's in it until it reaches a peak pressure that opens the aortic valve. And now the LV boluses blood out from the LV into the aorta. And remember, that blood in the aorta causes the aortic pressure to go up. This gray line here is the aortic pressure. And when the aortic pressure goes up, when it's higher than the LV pressure, your valve will close. That's when your aortic valve closes. That's really important. So in your minds, what you're going to remember is your LV fills, then it contracts. That makes pressure go up. When the pressure in the LV is greater than the pressure in the aortic valve opens. The left ventricle boluses blood into the aorta. And when the pressure in the aorta is greater than the pressure in the left ventricle, the aortic valve closes. Okay. Now, that aortic valve closes, and now we've separated basically the LV from the aorta, and the blood runs off into the periphery. And that's fantastic. And the LV relaxes. It's relatively empty, and it relaxes. And then it fills, and you have an atrial contraction. Then the mitral valve closes. LV contracts against the volume, and when it reaches a pressure higher than the pressure in the aorta, the aortic valve opens. LV boluses the blood out into the aorta. When the pressure in the aorta is greater than the pressure in the LV, the aortic valve closes. Pretty simple. It's just a pressure gradient. Okay? But what's really, really important for us to remember is we don't really see this. What we can see is the electrical event that has the corresponding mechanical. So your QRS is followed by LV systole, and your T wave is typically followed by LV diastole. So very roughly, we're going to say at the end of the QRS, your aortic valve opens, and at the end of your T wave, your aortic valve closes. So that's very simple, okay? And during this period of time, what you're actually looking at ventricular contraction, ventricular emptying, and initial ventricular relaxation. Ventricular relaxation is from the end of the T wave to the beginning of the next QRS. So at the bedside, I have to say, when I'm thinking about this, QRS to T wave is going to be considered systole. T and a T wave, or even depending on how fast the heart is beating, even mid-range of the T wave to the next QRS is considered diastole. Now, if my aortic valve closes and is meant to be closed during diastole, okay, what I should only hear are my normal heart sounds. First heart sound on ventricular contraction and aortic valve opening and mitral valve closing. And the second heart sound on ventricular relaxation, which is aortic valve closing and mitral valve opening. So that's first heart sound and second heart sound. So I have at my bedside with nothing extra except a stethoscope and a bedside monitor with EKG. I have the tools that I really need to actually determine what kind of abnormality is occurring. Now, the only thing I'm talking about today is aortic regurg, but there are many other events: mitral regurg, mitral stenosis, aortic regurgitation, tricuspid, blah, 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 pulmonic. But I'm focused on aortic regurgitation, which means that when my aortic valve was supposed to close, it didn't close completely, and blood goes back into the left ventricle. And I hear that blood movement as a blowing, hollow, diastolic murmur. And traditionally, it's a diastolic murmur that is really loud and then gets softer. So at the beginning of diastole, just after the T wave, just after the second sound, if I hear it, I'm going to hear a blowing, whooshing sound that's relatively loud and that gets much softer, because as blood moves off, less blood is regurgitating into the left ventricle. So really, really important, because I, as a bedside nurse, I should be thinking about heart sounds, and I should be able to identify the period of systole, which is really from QRS to T wave, and the period of diastole, which is from T wave to the next QRS. Systole, diastole. And when I identify a murmur, I have to identify, did it occur in systole or did it occur in diastole? And then I say, is it blowing or howling or whooshing, or is it humming? Humming murmurs typically are stenotic. Blowing, whooshing, hollow, those are typically regurgitation. So doesn't mean you're always going to be right, but you're going to have that basic methodology. So there are lots of things. This is all called the Wiggers graph. It correlates your LV volume and your LV pressure, right? Your LV volume, which is the red line, your LV pressure, which is the purple line, to your aortic pressure and to your atrial pressure, and then correlates that to your EKG, which we can look at no matter what. We can look at the EKG and on the monitor. And with our stethoscope on the chest, we're not looking at the chest, we're looking at the monitor. We're going to identify, when we hear this abnormality, did it occur between the QRS and the T wave, or did it occur between the T wave and the next QRS? So I'm looking at the monitor, but I'm listening to the heart sound, and I'm trying to identify the cycle where that sound is occurring. Systole, QRS to T, diastole, T to next QRS. And you can see, of course, this is much shorter than this is. This is much longer. Okay, so that's really very basic, very basic. And it's important to remember that valves, integral valves, meaning no problem with the annulus, cusp, or commissure, that the valves open and close in response to pressure differences. So the LV pressure has to go up to open the aortic valve. The aortic pressure has to go up to close the aortic valve. Ventricular pressure must go up to open the valve, aortic valve. That's the only one we're talking about here. And aortic pressure has to go up to close the valve. But the valve is fragile. I mean, it's not terribly fragile. I'm 71 years old and all my valves work, so it's not terribly fragile, but they are fragile and they're at risk when you have endocarditis or when you have traumatic injury or when you have CV surgery. Your valve is fragile in that way. And the best thing for us, without looking at any pressures or volumes, because you might need a PA catheter to do that, or you need to be in the cath lab to do that. Just looking at EKG and heart sounds, but not heart sounds, I'm sorry, not with those yellow disposable stethoscopes, not with a blue disposable stethoscope, not with a $29 Lippincott that you bought when you were in nursing school, but with a cardiology level stethoscope. So quite honestly, those are $200 or more dollars. So I hate to equate expense with value, but it's a valuable investment, a good stethoscope. So I'm listening with a great stethoscope and I'm looking at the EKG and I'm identifying where that sound occurs. Does it occur in systole, which is really short, or does it occur during diastole, which is really long? Okay, so that's really important when I think about my valve function. And remember, today, I'm happy to talk about anything you like, but today our focus is on acute aortic regurgitation, which remember is not necessarily a CV event. So it is important to remember that valvular stenosis is obstruction to flow forward, okay? So if my valve doesn't open, but it's narrowed, it's kind of glued together, and now the opening is tiny instead of big, it's tiny, my ventricle has to push really hard to push that blood through that stenotic valve. That pushing blood through the stenotic valve is heard during systole. Remember, we're just talking about aortic. We're not talking about mitral or tricuspid. We're only talking about aortic. Stenotic sounds, when I'm concerned about the aortic valve, a stenotic sound occurs during systole. So from QRS to T wave, really short period of time, and usually humming. And it doesn't usually obliterate heart sound 1 and 2. I can hear 1 and 2. So between 1 and 2, so love dub, love dub, love dub. Valvular regurgitation, which is incompetence or insufficiency, occurs during diastole, which is much longer. It gives me more time to listen to that sound. And that's because the valve didn't close. So I have a reversal of blood flow back into the ventricle, which is just relaxing, but isn't completely relaxed. So the possibility is blood flow may go back in and it may come back out. And so oftentimes I'm going to feel double hump pulse. That's called pulsus bifurans. If I have an A line, I'm going to see it on my monitor, and I'm going to show you that a little bit later. Lots of times, the valve itself can be both stenotic and regurgitant. If it's stenosed, but the opening is fairly wide, you'll have a stenosis on systole and a regurg on diastole. So it'll be whoosh, 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 whoosh. So I've got like all these abnormal sounds. Nobody's asking you to be an expert. Just identify that you have an abnormal sound. I can't tell you how many times I see people say S1 and S2, no other abnormal sounds. I got a patient who's got a hum and a whoosh. They don't even have a lub and a dub. So that tells me you didn't listen, or the stethoscope you're using doesn't work. You're looking at what the person before you put and you're mimicking the same thing. That is just completely inappropriate. You have to listen. You have to listen as part of your physical assessment. And you're definitely going to do that on people who've had an MI. You're going to do it on people with CT surgery, but you're also going to listen to that in people who have suffered a trauma, especially patients who have had a blunt chest injury. So again, it's not just about CVICU, my friends. Okay. Now, lots of times when you have one valve lesion, it causes another. So when I have aortic regurg, I can ultimately also have mitral regurg. But the most combinations that are common are these here, mitral regurg and aortic stenosis. So I've stenosed my aortic valve, my LV gets dilated, and now I'm regurgitating blood back through the mitral valve. Mitral stenosis and tricuspid regurg are very common. Lots of combinations that you might see. Okay, so now I just want to draw this as it's related to the aortic valve. I didn't draw this, somebody else did. It's fantastic. Here's your aortic valve. Your aortic valve should always be open during systole. But if it doesn't open all the way, that's stenosis, right? It's pretty straightforward. Open on systole, doesn't open all the way, it's stenosis. So you have a systolic murmur that is humming. It's supposed to be closed on diastole, but it doesn't close all the way. So you are going to have, excuse me, I have to plug my computer in. I didn't realize I hadn't plugged it in because I got my plug ready, but I didn't plug it in. My battery's just about to do it. Beautiful. Okay. So if it doesn't close all the way, I'm going to have regurgitation. Okay. And regurgitation gives me a whooshing, blowing, kind of a higher pitched murmur that occurs when we're talking about the aortic valve only, or aortic and pulmonic, that occurs only during diastole. So of critical importance is first to hear the sound that's abnormal, and then identify where it is in the cycle. Is it during systole or is it during diastole? With acute aortic regurgitation, you will hear a whooshing, blowing, hollow sounding murmur that occurs on diastole that starts loud and gets soft. And so we use musical terms for that, and that is called decrescendo. Starts loud, gets soft. Starts loud, gets soft. Okay? That occurs during diastole. So this is described as a decrescendo, hollow, diastolic murmur, and I've heard it best at the aortic site. Okay. Now the aortic site, remember, is on the right side, my patient's right side of the sternum at the second intercostal space, because the LV ejects blood up towards the right and the arch then confers over to the left. So I'm going to hear it best at the aortic site, which is the second intercostal space. So just in case we didn't get it, stenosis, the valve doesn't open all the way, and regurgitation, the valve doesn't close all the way. Okay, that's all. It's pretty straightforward. Not so easy to identify, but pretty straightforward. But here's the problem. With aortic regurgitation, the leak or the backflow of blood that occurred because of the incomplete closure of the valve, again, could be the annulus, could be at the cusp, could be at the commissure, doesn't matter. That backflow of blood increases the volume in the LV. The LV then has almost a double ejection. That's the pulsus bifurans. I feel it like this, boop, 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 boop. I see it if I have an A line, or if I have a good plus signal, the pulsatile signal on pulse ox, I see a double hump. A double hump almost always indicates that you have pulsus bifurans, and that almost always indicates that you have an aortic regurg. Okay. Now, when it happens acutely, the heart doesn't dilate. The heart never dilates acutely. That takes time. With chronic aortic regurg, you have time to dilate the heart, to dilate the internal chamber. But when this occurs acutely, like in that little 16-year-old girl, that was an acute traumatic rupture. She had some injury, and that injury made the tissue even more fragile, and then it ruptured. The tissue ruptured. So now she's got acute aortic regurg. People with chronic aortic regurg, so it's a slow process developed over time, what you see is the heart dilates and the muscle hypertrophies in order to move that volume better. So really important to understand that what I'm talking about today is not chronic regurg. I'm talking about acute regurg. I'm talking about something that's life-threatening, because instead of blood going forward, blood goes backwards. And because the ventricle can't dilate, that blood goes backwards into the LV, and it ultimately forces blood back into the LA, which then forces that blood into the pulmonary vasculature. So now my patient almost immediately will have acute, profound pulmonary edema. So they looked fine 2 hours ago, and now their pulse ox has dropped. They have pink frothy fluid. The lungs are wet, and your stethoscope goes immediately to that aortic site. And now you're hearing the diastolic whooshing murmur of aortic regurgitation. So really, really important. That patient may get acutely uncomfortable, diaphoretic, syncopal, pulmonary edema, palpitations, very short of breath. And that's going to also occur in patients who have chronic aortic regurg. It's generally progressive. So remember, it's acute with acute symptomatology, or chronic with evolving symptomatology. So really important is we're going to look at the pulse, We're going to listen to the heart sounds, and definitively for diagnosis is always echocardiogram. Okay, so just in case we're unclear, there are many causes for aortic regurgitation, but when we talk about acute aortic regurgitation, that means something happened that caused an acute rupture of one of those three. Typically, you see that in infective endocarditis, in a traumatic injury, in aortic dissection, and post MI or post cardiovascular surgery. So those aren't included here. So we're talking really about acute valvular dysfunction, okay? You can have congenital dysfunction, and that just occurs because you have an abnormal structure. You can have an acquired dysfunction that occurred because you have underlying inflammatory diseases, or you have uncontrolled hypertension, or you have acquired valvular dysfunction that occurred from these reasons. So it can be congenital. That's going to be typically, if you survive past your first 2 or 3 or 4 years, that's going to be chronically worsening. And if it's acquired, it could be chronically worsening or it could be acutely worsening. So that's what we're looking at here today, is acute problems. And again, think about this in every patient that has endocarditis, every patient who's had a trauma, especially a jarring trauma like a fall from a 2-story building, or like a blunt chest injury, anybody who has aortic aneurysm and aortic dissection, anybody post a large anterior MI, and anybody post cardiac surgery that might have involved the outflow tracts of the LV. That's why you have to listen when report is being given by the CT surgeon, so you can hear what happened at the outflow tract of the LV, so that you know you need to be watching for acute aortic regurgitation, which will kill your patient probably sooner than you even think about calling your surgeon. You're in the CVICU, your patient decompensates, now they've got acute pulmonary edema, they have profound hypotension, you're getting the APP, but really, you should be getting your APP and calling the surgeon, because that patient, this patient right here, this patient will survive only if you get them to the operating room fast. So you're in the trauma unit, you've had a blunt chest injury, and now all of a sudden you have fulminating pulmonary edema, your pulse ox has dropped, your peripheral pulse has dropped, your arterial pressure has dropped. You need a CT surgeon. Yes, get your attending or your APP, but you need to notify the CT surgeon that you have a suspected acute aortic regurgitation. Now, they may say, well, I'm going to talk to the APP or the physician. That's okay. You're going to document, I notified CT surgeon of concern for acute aortic regurgitation. Because the time is of the essence here when you have an acute aortic regurg. Okay, so just to talk about what that physiology is, which is so incredibly important when we're thinking about our patients here. With acute aortic regurgitation, remember that's regurgitation on diastole, so the murmur occurs during diastole. You have a significant increase in LV volume, okay? Now, if this is chronic, you're going to increase your LV mass. If it's acute, you're going to immediately go into LV dysfunction and left ventricular end diastolic pressures that are high, which then promote blood flow accumulation in the pulmonary vasculature. So again, remember, we're talking about acute. Now, you can have acute on chronic. So a patient may have chronic aortic regurg, but now they have an acute event, and that acute event throws them over into acute on chronic aortic regurg. They got to go to the OR. That's the only thing that's going to happen. Okay. Chronic regurg, we can treat differently. Acute regurg, you have to go to the OR. That's it. Got to go to the OR right now. That's the only thing that's going to save your life. Okay, so you're regurgitating your volume into the LV. That means that what's actually going to happen is that you have a double volume load in your LV, which may mean that initially they may increase their stroke volume, but eventually they're going to drop their their systolic blood pressure. But what also is happening is that you have reduced blood in the cusps where the coronary arteries arise. So although the patient is working hard, you actually have a reduction in their myocardial oxygenation. So I want to make sure you understand the heart's going to work hard, consume more oxygen, but the delivery of blood flow carrying oxygen to the myocardium is going to go down, and that patient's going to develop myocardial ischemia, which is further going to exacerbate their left ventricular failure that was occurring because volume was going backwards into the LV. This is all very important. Okay, now this is left ventricular in time, aortic diastolic pressure, and diastolic time. So your LV is going to be contracting much more rapidly. You're going to be in tachycardia. That reduces the time for diastole. Diastole is when you fill your coronary arteries. So that further puts your patient at risk for myocardial ischemia. Okay, so typically in the acute, not in the chronic, in the acute aortic regurgitation patient, their lungs are going to get immediately wet. You didn't have much notice, and all of a sudden they got pink frothy fluid. You listen to their breath sounds, you're hearing crackles or bronchi, and may start at the basis, but it's probably going to be about a third of the way up. Typically more lateral independent. If you can auscultate, if it's anterior, you're really in trouble. Their lungs are wet, so their pulse ox has dropped. And they have poor body perfusion, so their acidosis will get worse. Their requirement for vasopressor is probably going to go up. Their blood pressure has dropped. So they've got wet lungs and poor body perfusion, and they are going to die if you don't notify somebody and if you don't understand what should happen next. So this is basically, when you talk about wet lungs and poor perfusion, this is basic cardiogenic shock. And your patient is with acute aortic regurg. They go almost directly into class 3, then class 4 heart failure, and then cardiogenic shock. And if you don't know what you're doing and you're running around like a chicken with your head cut off and you're calling everybody else into the room to take a look, and you haven't called a cardiovascular surgeon or a surgeon, even just a surgeon, you are participating in poor practice. And really, you just need to understand their lungs get wet acutely, their body perfusion reduces, and you listened to their heart with a good stethoscope. So I don't accept an excuse when somebody says, well, I don't have a good stethoscope. Why not? You bought a Mercedes, you have radial tires on there, you wear some fantastic clothing and jewelry, you've invested in all those things. You didn't invest in a stethoscope and you work in a hospital with acute patients? I'm sorry. I don't buy that. That's the first thing you have to do when you're working with acute patients is buy a good stethoscope. And that's an investment in your patient's future and your future. So one less bracelet, one less radial tire. I have lots of bracelets, but I also bought a really good stethoscope. So I have lots of bracelets. I don't have radial tires. And I have a Mercedes that was gifted to me by my mother-in-law. So man, I don't have any worries. Okay. All right. But I'm just making a joke, but I'm telling you, investing in a good stethoscope is really important because you've got to be able to hear this. So what also is going to happen, that backflow of blood to the left ventricle, remember, in chronic aortic regurg, you're going to hypertrophy and dilate, and eventually that left atrial pressure that was caused because of the regurgitation into the left ventricle. Left atrial pressure goes up, left atria hypertrophies, your pulmonary pressure goes up, and ultimately you're going to end up with right ventricular failure. So eventually, with chronic regurg, you have left ventricular failure that then communicates to right ventricular failure. Now you have biventricular failure. So then you have a trauma, or you have a surgery, or you get pneumonia, or you get any other kind of flu, and you fall right over from being able to compensate for that chronic problem into being acutely ill. Now, surgery isn't going to be what we need to do for you at this point because you've had a chronic problem and you already have LV and RV hypertrophy. But it's really important to remember that we're trying to recognize the patient with acute aortic regurg to try to protect them from cardiogenic shock and heart failure. Okay, so we're going to go back to our patient number 1, 16-year-old girl, pediatric. It doesn't matter. She's 16, so she basically has cardiac structures just like an adult, and she has heart failure symptoms. She's 16. She shouldn't have heart failure. And so an investigation, or we looked at the chart and we say, oh, look, 6 months ago, she came to the hospital because she fell from a second floor of a building. And so remember, what we're going to suspect here when we hear that diastolic murmur is that she has an aortic regurgitation. That occurred because of traumatic injury. Okay. So when we have acute aortic regurgitation, you've got all that volume in the LV, but remember what I've said, the LV doesn't have time to dilate in response to that increase in volume. So LV pressure goes up really quickly, and blood in the pulmonary veins goes up really quickly. And then that pressure, that hydrostatic pressure in the pulmonary veins, forces the volume out of the veins, and that volume starts to fill the alveolus. And now I can't oxygenate. I'm having trouble breathing, and I've got pink frothy sputum because I've got pulmonary edema. And if it's severe enough, we would classify them almost right away. Poor perfusion, wet lungs, so they're cold in their body and wet in their lungs. That's a class 4 heart failure. Class 4 heart failure can quickly deteriorate to cardiogenic shock. And on top of that, because they're not closing their cusps, they're not loading the coronary arteries, the heart is beating fast. That leads to myocardial ischemia. They have clean coronaries, they just don't have blood in the coronaries. So this is a very nice little graphic of acute aortic regurg. Okay, so the blood is regurgitating from the aorta back in the LV pressure goes up, the LA pressure goes up, and that promotes stasis of volume in the pulmonary bed, and that causes your pulmonary congestion. Okay, myocardial ischemia, I've already explained that. Okay, the wall is pulled tight, it's very tense, that increases your oxygen demand. The diastolic pressure and the accumulation of blood in the cusps of the aortic valve reduces coronary perfusion. And so you've increased the demand for oxygen, but your coronary perfusion went down. That means decreased supply, and that gives your patient myocardial ischemia. So you might see some ST segment changes, but the patient doesn't have coronary artery disease. They have an acute aortic regurg. So really, really important, okay? No way to compensate with acute regurg because it happens too fast. So they rapidly decompensate, suddenly, severely short of breath. They may have chest pain if they can communicate that to you, but most importantly, you're going to see the evolution quickly of pulmonary edema and the deterioration into cardiogenic shock. Okay, so remember what cardiogenic shock is. It's hypotension with wet lungs. And if I have a way to look at cardiac output, I see that your cardiac output has fallen. Okay, so we're going to think about diagnosis, and that's only really if we have time, right? We look at the history, we do a physical exam, and the most important one is putting that stethoscope on the chest and evaluating the murmurs. Remember, this is going to be a diastolic murmur, loud at first and softer at the end of diastole. It occurs between the T wave and the QRS. So eyes on the monitor, find my place for my stethoscope, leave it there, eyes on the monitor, okay? Evaluate the patient. Are their lungs wet? Did their pulse ox drop? Are they less well perfused than they were the last time I saw them? I'm going to think about an EKG. I'm going to think about a chest X-ray. I'm going to think about an echo. I can consider a CT or an MRI. You have some autoimmune disorder, or you are an IV drug abuser. You have all these risk factors for acute aortic regurg. So that's what I'm thinking. I'm going to, first of all, before anything else, I'm going to notify my provider. I'm going to ask my provider to consider notifying a CT surgeon. I might not do it myself, depends on where you work and what your relationships are. And I should anticipate that while I'm waiting for everybody to come, the time is ticking, but I'm going to try to get a stat EKG as fast as possible, stat chest X-ray as fast as possible. Here at Grady, getting an echo is difficult, but depending on where you are, your provider can do a POCUS, and that's the point of care ultrasound. So remember what the goal of POCUS is. There's really 4. Look at your abdomen, look at your pipes, those are your veins, look at your pump, that's your heart, and look at your lungs. Okay, those are the 4 things. Abdomen, lungs, heart, veins. Abdomen, lungs, heart, and veins. So you need somebody who's experienced with ultrasound. Can't be somebody who doesn't know what they're doing or they're just learning. You need an expert in bedside ultrasound, but you should be able to do a bedside ultrasound pretty easily. It's not as highly tuned as an echocardiogram, but it's, you know, it's kind of, it's much more generic, and it's a lot harder to actually tell what's going on. But okay, we can ask to do that, because we know here at Grady, unfortunately, it takes some time to get echo. So I'm going to be moving fast here, my friends. I'm making sure we're getting an X-ray. I'm making sure we're getting an EKG. I'm asking for somebody to bring the bedside ultrasounds of the physician or the APP. They should be qualified. They should be good at it, but they need to look at pipes, pump, pulmonary. We don't really need to look at the abdomen here. We're not worried that you have abdominal bleeding, or we don't need to do a fast. We're just looking at pipes, pump, pulmonary, veins, heart, lungs with that POCUS. Okay. One of the most important things that I've said to you is that the heart sound is vital. So again, looking at my patient, this is my left second intercostal space, but the patient's right intercostal space, and I'm listening here. This is where I should hear an aortic murmur, okay? And I want to remind you with aortic regurg, so look at this visual. At the beginning of diastole, it's loud, and at the end of diastole, it's soft. So it's so I might hear lup-dub, lup-dub. Now, obviously, I'm a human being, and I can't mimic how fast this occurs because it's really fast. But I've got to have my eyes on the EKG and my stethoscope on the patient's aortic site, which is second intercostal space, right side of the sternum. Okay, well, I don't have an EKG because maybe they haven't gotten hooked up to the EKG, or they're on 12A, but they're not in the ICU, or they're on, 5A. Okay, well, guess what? Carotid pulse, lub-dub, lub-dub, lub-dub. I'm lifting my fingers up to show you that I'm feeling the pulse. Lub-dub, 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 shh, lub-dub, shh, lub-dub, shh, lub-dub, shh. Okay, so I should be able to identify systole by lub and dub, and diastole, which should be silent. I'm hearing that shh, shh, that decrescendo blowing sound that tells me the patient has aortic regurgitation. Okay. On EKG, I may see nothing or I may see something. Typically, in a person who has acute aortic regurg, they're not going to have EKG changes. Patients who have chronic aortic regurg are going to have hypertrophied left ventricle. You're going to see patterns associated with left ventricular hypertrophy. That might be left axis deviation. That may be a delay in conduction. Lots of things that you have to think about. EKG is not really helpful in patients with acute aortic regurg because we've got to see some change in the dynamics of the musculature. That occurs more with a chronic problem. But I do want you to look at it. So really, I believe every bedside nurse who works with acute or critical patients takes a 12-lead course. And some of you have taken 12 leads with me. You know, it's 3 days, 3 or 4 days, depends, not all at once, every week or something. That's pretty darn intense. And I make you read like 200 EKGs, and we go over lots of things in that course. But all I'm going to say here is when I'm looking for LV hypertrophy, I'm looking for the left-sided chest leads. That'll be V4, V5, and V6, left-sided chest leads, that the R wave is really tall and that they merge into each other. So this is what I call Dr. Dollar's sign for LV hypertrophy. Left-sided leads merge into each other in the R wave. On the right side leads, which is primarily V1 and V2, but may also include V3, you're seeing that the downward wave of V2 merges into the upwards wave of V3. That's consistent with LV hypertrophy. So I'm not here to teach 12-lead EKG. That's really intense. I mean, I could do a 12-week course in 12-lead EKG on these 1-hour topics. That'd be fine. I'm okay with that. But what I'm saying to those of you who are new to critical care, maybe not in critical care, that when you look at an EKG, when you see these waveforms are merged on the left side like this, they're upright, which means conduction is going to the left, but they're merged into each other and you can't really define where one ends and the other begins. That's Dr. Dollar's sign for LV hypertrophy. So we can see that quite beautifully there. It is really important to remember that EKG is not specific, and the patient may have other types of disease that cause changes in EKG. So I could be an uncontrolled hypertensive patient. That doesn't mean we're not taking medication. Maybe we take it sometimes, maybe we don't take it sometimes. I could have uncontrolled hypertension and acute rupture my aortic valve. And when I take a look at your EKG, it looks like you have LV hypertrophy. That doesn't mean that you actually have chronic aortic regurg. You may have acute aortic regurg on top of a chronic problem, which is your hypertension, okay? So very, very important for us to remember that. When we see new onset atrial fibrillation or new onset bundle branch block, so conduction to the left and delayed, so wide time, we're going to consider with left bundle branch block or LVH, new onset AFib, or other kinds of atrial ectopic beats. In conjunction with that, stethoscope on the chest and evaluate whether or not you hear a diastolic murmur. Every single nurse should be able to distinguish a diastolic murmur. It takes time. You got to listen to a lot of hearts. You got to listen to a lot of normal hearts before you listen to abnormal hearts. But every single nurse, you don't have to read an EKG. You have to distinguish a diastolic murmur. That's all. Stethoscope on the chest, and in this case, at the aortic site, listening for a decrescendo blowing murmur occurring during diastole. That's the most important thing you can do. This is another patient that just, again, what you're seeing is the waveforms are merging. I can't separate the waveforms. Completely downwards on the right side, meaning it's all going to the left heart, and it's up on the left side, and it's a big voltage, but not taking a lot of time. Time is measured by width. So it's not taking much time, but voltage is definitely going to the left. It's left ventricular hypertrophy. So that already tells me I have an issue. And the chest x-ray, really, really important when we take a look at a chest x-ray. What we're really going to look at when we talk about patients with acute aortic regurg is what we expect to see with acute regurg is we see vascular congestion, but we don't necessarily see a large heart or widened mediastinum. Now, if you're dissecting your aorta, and that's what's promoting aortic regurg, you're going to see a widened mediastinum. Okay, that's the cause of your aortic regurg is the dissecting aortic aneurysm. But in acute aortic regurg that just comes because you have a ruptured leaflet, which is the most common that we see, okay, you are just going to see vascular engorgement. So you're going to see a lot of white where the vessels lie. And a lot of times what you're going to see is what we call curly B lines, which are horizontal lines that go from the diaphragm upwards. Those are vascular engorgement lines. And that's what you're going to see with acute aortic regurg. With a more chronic aortic regurg, now you've got a widened mediastinum here, but with a more chronic aortic regurg, you're going to see a very large heart. You don't see a large heart with acute aortic regurg because remember, the heart hasn't had time to compensate. Okay. What's really definitive is your echo. Okay. So I'm not trying to make anybody be an echo expert. I am not an echo expert. Okay. But these are some visuals that just show you how blood goes forward and backward almost equally. Blood goes forward and backward, forward and backward, forward and backward. So we don't expect to see equality on both sides. Sometimes you have a little bit of backward, but your backward is almost as great as your forward. That's the regurgitation. So this is that 16-year-old girl's echocardiogram. Again, I'm not an echo expert. I'm not trying to make you an echo expert, but what I want you to appreciate, and you're going to see here, is that your aortic valve does not completely close, okay? Now, why we look at this with weight is that we're looking at blood goes forward and then comes backward. Blood goes forward and then comes backward. Blood goes forward and then comes backward. So we're seeing that blue light, it goes forward and then it comes backward. It goes forward and then it comes backward. I'm not expecting you to read an echo, but I want you to understand why the echo is so significant, because the echo is going to tell us about how much volume is going forward and how much volume is going backwards. And that tells us about the depth and the severity of your aortic regurgitation. If you have time for it, you can't do that with a POCUS. It has to be an echocardiogram. It can be transesophageal or it can be transthoracic. But if you take a look at that, look at how much blood is going backward, how much blood is going forward, how much blood is going backward, how much blood is going forward. This is the echocardiogram of that 16-year-old girl. Okay, so here's her interpretation. The TTE, transthoracic echo, shows that the LV is dilated, has global left ventricular dysfunction, and severe, profound aortic regurgitation with that holodiastolic flow, meaning you have flow backward, equal almost to the flow forward, backward, forward, backward, forward. And that was that visual that we looked at. And that occurred because she had a traumatic rupture of her right coronary cusp, which also means that she has some limitation of blood flow through the right coronary artery. She was lucky, she's young, her RV size and RV function were preserved. So the thing to remember in acute aortic regurgitation, almost always, your patient is going to get short of breath. Now they're going to get acutely short of breath. They're in your care. They're not walking around. We're not talking about how many pillows you need at night. Those are chronic things, okay? Acutely short of breath and typically with pulmonary edema. So they're coughing. They've got, pink tinged, frothy fluid. They may have chest pain. They all of a sudden feel acutely exhausted, and they may have palpitations either because of arrhythmia or because the LV is being very forceful. That's in the acute aortic regurgitation patient. And typically, if I'm trying to differentiate on patients that may have other issues, it may be that I'm using too much epinephrine or too much norepinephrine if I'm giving that continuously to try to treat their blood pressure, but I put them into a sympathetic overdrive state. Or if they're hypovolemic, I can have kind of this whole dynamic change in the way my circulation is occurring. Lots of other things cause dynamic changes in my circulation. They're all really important. Typically, I'm going to suspect that hyperdynamic circulation, which also is part of aortic regurg early. That's called a wide pulse pressure, meaning systole goes up, diastole goes down. The difference between them is greater than 40 millimeters of mercury. So again, I'm thinking about, I'm the bedside nurse. I don't need to do a differential diagnosis. I'm the bedside nurse. My patient got acutely short of breath. Their pulse ox dropped. Their forward flow has diminished. Their pressure is down. The pleth is decreased. My stethoscope is on the chest. My eyes are on the EKG, or my fingers are on the pulse, the carotid pulse. And I'm looking for a diastolic decrescendo murmur, which indicates to me the patient has had an acute aortic regurgitation. Everything else that happens comes after that, because you're the one at the bedside. You're responsible. You are responsible for the initial evaluation of that patient. They got acutely short of breath and their lungs are wet. Their pulse ox has dropped. Stethoscope on that heart. Listen to whether you have acute aortic regurg. The other thing you'll listen to, although that's not part of what we're thinking about here, is you're going to listen to the mitral site, which is fifth intercostal space, left lower sternal border or left lateral. So I'm listening to aorta first, but I didn't have a murmur there. I'm now going to go over to the mitral site and listen to see if I have a murmur there. That's going to happen more acutely in patients post significant anteroseptal or anterior MI, but it can also happen with the posterior MI. So by the way, any MI, you should always be aware that they can rupture their papillary muscle and have acute mitral regurg. Not the topic of our conversation today. So again, physical findings that you typically are going to hear or find. That diastolic blowing murmur, typically we hear that best at the aortic site, okay? You might also hear it at the left lower sternal border, but that's usually more discreet, much louder when I hear it always at the aortic site. Wide pulse pressure. So systolic pressure is up, diastolic pressure is down. Wide pulse pressure. That's because of that regurgitation of the blood into the LV. And if I'm looking at and listening to the chest, I may also see, but I don't always see it, is that the point of maximal impulse, which is fifth intercostal space, mid-clavicular line, has shifted over to the left. So when I evaluated my patient, because that's part of your physical assessment, is to actually know where their PMI is, point of maximal impulse, where you feel the heart pulsing the most. Typically, fifth intercostal space, mid-clavicular line has now shifted more laterally, and that's because of that bigger heart with that giant stroke volume. Now, this is a patient with an A line, and that's all I'm talking about here. This is a very nice arterial pressure, peak, dicrotic notch, fall to diastole, peak, dicrotic notch, fall to diastole. Even though the patient's hypotensive, this is a really nice looking A line. But with a patient who has aortic regurg, if they have an A-line, or I'm feeling the pulse, or I'm looking at their pleth, what I expect to see is this prolonged systole, which may actually be double hump pulses, like you see here. Here's the first hump, here's the second hump, or plateaued pulses that you see here on the A-line, okay? And again, this patient's diastolic pressure is not that low, but their systolic pressure is quite elevated. This is a widened pulse pressure that I expect to see in this patient. And I walked in the room, I saw this patient. I didn't even look at the patient, didn't know anything about the patient. I looked at the A-line, I said, your patient has aortic regurg. Somebody said, well, how do you know that? I said, look at the A-line, look at this visual. So I snapped a photo and then I captured a piece of it and enlarged it for you. And they went immediately to the chart and they said, oh my God, they do have aortic regurg. Okay. Now, this is not acute. Patient wasn't short of breath. Patient wasn't having chest pain. This was a chronic patient. But you should be able to recognize that when you're taking the pulse, when you're looking at pulsatile waveform, you should be able to say, oh, I think this patient may have aortic regurg. And I'm going to put that stethoscope on that aortic site. Then I'm going to listen to the left lower sternal border. I'm going to do those two sites, and I'm going to evaluate them very effectively. I can do that. I'm the nurse. I have a stethoscope. I need to look at it. And this is called pulsus bifurans. Pulsus bifurans is what you see when patients have aortic regurg. Now, there's a lot of other things that you probably aren't going to see, and I've listed them here, but you're probably never going to see them. But there are two that are really, really obvious. Some of these require a lot more finesse. But one of them is if you look at the nail beds and the nail beds are pulsing because you get a double ejection from the LV because of the regurgitation, the nail beds are pulsing, that's a positive sign for aortic regurg. If the uvula is pulsing, so you ask them to open their mouth, probably you're not going to do that, and the uvula, the little hanger in your throat, is pulsing, that indicates aortic regurg. But here's the other one. If the head appears to be nodding in time with the heartbeat because it's that double ejection is being transmitted up into the carotid arteries, so the head pulses with the heartbeat. You might walk in that room and say, oh, that guy's got Tourette's or something's wrong with him. But then you correlate that pulsing with your EKG, and every time they have a cardiac ejection, the head moves. These other ones are require a little more finesse, and you're not necessarily going to see these. You might not find them. You rarely and infrequently are going to see them, but it's just a way for you to evaluate your patient. Now, let's look at that chest x-ray. In chronic, remember, you're going to have a dilated ventricle, you're going to have cardiomegaly, but you really don't have that much volume in the pulmonary vasculature. With acute, on chest x-ray, the LV is traditionally the normal size, but you've got a lot of pulmonary vascular congestion. So remember, in acute, you immediately fill the pulmonary venous circulation and transcend into pulmonary edema. With chronic, you've got a big heart, you've got heart failure, you have a poor ventricular ejection because your ventricle is so dilated, but you don't really have a lot of pulmonary vascularity. You have some, but not a lot. Okay, so I want to make sure we understand physiologically the difference here. In acute aortic regurgitation, we're acutely regurgitating blood into the LV, but the LV hasn't had time to dilate or to increase its muscle mass. So the LV is relatively small, the pressure in the LV goes up, the pressure in the LV forces volume back into the LA, pressure in the LA goes up, and that forces volume to stay in the pulmonary veins, causing almost immediately after rupture or regurg, almost immediately pulmonary congestion. So again, you have new onset pulmonary congestion, you put your stethoscope on the patient, you hear the lungs are wet, you put your stethoscope at the aortic site in the left lower sternal border, and you hear a diastolic whooshing murmur. That patient has acute aortic regurg. You call your doctor, you say, I have new onset pulmonary edema, and I believe I am hearing a diastolic murmur in a decrescendo state, blowing. I think this is acute aortic regurgitation. You need to come now, not after rounds. This is an emergency. With chronic aortic regurg, you've had time for the LV to dilate, for the muscle mass to increase. That's why they have LV hypertrophy. They have a very big, look at the difference. This is a drawing, but it's so good. The difference between the diameter at the LV with chronic aortic regurg and acute aortic regurg. So basically your LA hypertrophies, but the pressure, it's larger, but the pressure is relatively normal or just mildly increased. And I don't traditionally see pulmonary congestion. So that pulmonary congestion that occurs quite rapidly is a really good sign that you have an acute regurgitation. Okay. Again, you're going to have to determine, is it aortic or is it mitral? If you regurgitate in the mitral valve, that's systole. If you regurgitate in the aortic valve, that's diastole. That's really straightforward. Mitral regurg occurs during systole, aortic regurg occurs during diastole, and I have acute pulmonary edema. So those are two things that are pretty simple for me to look at if I have a good stethoscope and I am listening to people's hearts and lungs, and I'm practicing all the time, which, by the way, just because you get a disposable stethoscope doesn't mean that's the one you're going to use. Unless you're in a COVID room or some highly transmittable disease room, you don't want to take your stethoscope in there. But otherwise, you should be using your good stethoscope. It's part of your evaluation, and it really helps you. So really important to appreciate that in chronic aortic regurg, systolic pressure may be up, it may be normal, it may be low. Diastolic pressure, though, goes up. In acute aortic regurg, diastolic pressure goes down. Systolic pressure may be high, may be normal, may be low. The aortic pulse pressure is wide. The heart rate goes up. In acute aortic regurg, you have a loud S1, you have a decreased S2, and really important, in both of them, you're going to have a diastolic murmur. So I'm not saying that these are definitive things for you to look at because they're very similar to each other, right? You got an increased S1 and a soft S2 in chronic regurg. You have an increased S1 and a decreased S2 in acute regurg, okay? Typically, you're going to hear very early on an S3. That's the third heart sound, which occurs between S2 and S1. And the fourth heart sound, you're never going to hear because you have not gotten to that level yet. So again, these are kind of discrete things. I'm focused on, are your lungs wet? And do I hear a diastolic murmur? That's all I want you to focus on when you're thinking about these patients. And the severity is really based on the impact on the blood flow to the periphery. So I have cold fingers, prolonged capillary refill. I've lost my pulse ox. I've lost my pleth. This is really acute. When that happens, I don't have any time. That patient's got to go to the OR because now they have no peripheral blood flow. So these other things are really, really important. But the most important one to you is what's happening to your peripheral blood flow. Because when you have acute aortic regurgitation and then profoundly diminished peripheral blood flow, your moments, really, I'm not saying absolutely 5 minutes or 3 minutes, minutes, maybe 50, maybe 60 from death. You have to work fast. That's why we have to actually be able to look at this and say that this is important. With acute aortic regurg, almost always caused by aortic root failure, by a tear of the cusp, or by a leaflet perforation that can occur when you have infective endocarditis, okay? Presentation is almost always because you have profound pulmonary edema. So remember, new onset pulmonary edema. So my friends, you see it all the time in CVICU. You see it a lot with people post-MI. Not going to be quite as experienced at it in the trauma bay or in the trauma ICU, surgical ICU, but you need to be thinking about that. Acute, exacerbated pulmonary edema, stethoscope to the chest, listening for that diastolic murmur. That is a true emergency. You have to go immediately for CT surgery for valvular repair. Now, really important to understand at a place like Grady, where we don't have a perfusionist on staff, we've got to call somebody in. It's going to take a little bit of time. You need to get that CT surgeon there. When the CT surgeon is there, maybe when the trauma surgeon is there, it just depends, or a vascular surgeon is there, just depends. If you have acute aortic regurgitation in the window of time that we're going to try to get that patient to the OR, despite everything you know and you think, you may need to use a vasodilator. Your tendency is, I want to use a vasoconstrictor. but the probability is you're going to institute a vasodilator to make it easier for blood to go forward than it is to go backwards. So you may use a vasodilator like nitroglycerin, cardine, probably not nitroprusside, so unpredictable. Nitroglycerin at arterial levels, so 50 or above. And you might give some volume, probably not going to give an inotrope. All you want to do is reduce the resistance pressure in the aorta so blood goes forward. You're not going to do that without an order, but you should anticipate that while we're getting ready to go to the OR, we might need to vasodilate the patient. If his blood pressure drops, you're going to give volume, or you're going to withdraw the vasodilator. But it is a possibility during an acute aortic regurgitation. Single most important thing, get to the OR right away. Get to the OR right away. So if you're at a place where they have perfusionists on staff who are in-house 24 hours a day, you can get the OR right away. Your CT surgeon is in-house. You get to the OR right away. So that's in a place that maybe does 5 to 10 to 15 to 20 cardiovascular surgeries a week. In a place where you're doing 1 to 2, you probably don't have a CT surgeon in-house. So you're going to have an intermediate step. And that intermediate step, we have to really think about if this is actually aortic regurgitation, vasopressors are going to make the situation worse. So I just want you to think about it. Doesn't mean you're never going to use a vasopressor, because there's no never in critical and acute care. But I just want you to remember your goal is to get blood going forward, not backwards. And so that's going to be really, really important. So you might give your patient dobutamine. You'll give them a vasodilator. Typically, it'll be dobutamine and nitroglycerin. Nitroglycerin is going to be really, really important because you want to decrease afterload. You do not want to use a beta blocker, and you do not want to use balloon pumps. What you want is to get to the OR. So usually a vasodilator, not nitroprusside, usually nitroglycerin. I'm sorry, it says that. And we're not going to use dopamine. Typically, we're going to use dobutamine if we use it at all. We want to increase forward flow, and we want to reduce resistance to forward flow. So that's why we're going to use that combination. And we're only going to do that because we can't get to the OR immediately. But the best bet is get to the OR immediately. That's going to be the very best thing. Okay, so back to patient 1, who we started off with. Okay, so remember they took a look at that echo, and they said, oh my gosh, she's got severe LV dysfunction and profound regurgitation. They did a CT. I can't believe they were able to do that. Her aorta did not have any evidence of dissection. They wanted to be sure she wasn't dissecting because it was a traumatic injury. And they saw that actually the coronary cusp and the coronary sulcus right under the right coronary artery, there was a rupture there. She had no ventricular defect, no atrial defect. Pulmonary arteries and right-sided valves, so tricuspid and pulmonic, were not affected because this just happened, okay? They took her to the OR, and they actually discovered that the aortic valve, the tricuspid aortic valve with that right cusp, was very significantly torn. They couldn't repair it, so they gave her a mechanical valve. 1 year after surgery, because the people who were evaluating her recognized what happened. That's the single most important thing in this patient's outcome, was that the people who evaluated her recognized what happened. And you know how they recognized it? Because she had a diastolic murmur at the aortic site. That's how they recognized it. And from there, everything else evolved and flowered. 1 year after, with surgery and some medical therapy, patient is now in class 1 for heart failure, which means lungs are dry, periphery is warm, heart failure is absent, and she has a 57% LV ejection. If that was your 16-year-old daughter, you would hope you had a nurse who had a stethoscope and knew how to use it, because the single most important factor in the early evaluation of that patient was the evaluation of that diastolic murmur. And that's what started every wheel going forward. So I appreciate that you joined me here today. Remember, this patient came from a case study that was published in the Journal of American College of Cardiology, the JACC. This was not my patient, but this was such a great patient, and the echocardiograms and the video were beautiful and ever present. But what was most important to me was the thing that started every wheel going forward was the evaluation and the recognition of a patient with heart failure who has had a blunt injury, and auscultating that aortic regurgitation murmur. That's what started everything going. And that, my friends, is in your hands. You should be listening, particularly when you have acute pulmonary edema and signs of heart failure, stethoscope on the chest. Aortic site, left lower sternal border. You hear a diastolic murmur, whooshing. You got to notify somebody right away. You got to give your other patients away. You got to notify somebody right away, and you need to be sure that surgery is also notified. So I appreciate you very much. Thank you so much for joining on Wonderful Wednesday today for acute aortic regurgitation. I'm going to end my recording now, but I am going to be available for about 5 minutes for any questions after I end the recording. Bye-bye for now. See you next week. And thank you so much for joining. Bye-bye.